Good evening, everyone. Thank you so much for joining us. Uh, I'm Khushi Goyal, a project associate working with Superheroes Against Superbugs, and I'm so glad to see you all here on Sunday evening. Before we begin, I just thought I can just briefly introduce what we are going to be doing today. So we have a panel discussion planned for us, and along with that, we have some activities. Majorly, we are dealing with the elephant in the room, which is antimicrobial resistance. And during the course of the next 2 hours, you'll understand what AMR is I believe, from a more uh, nuanced point of view. And I just thought let's begin from, since you are all doctors, I hope that you have heard AMR at some point of time. So before we actually dive into our discussions, I would just want you to come with me on this side and tell me, what do you know about AMR, or what is the one word that comes to AMR, comes to your mind when you hear about AMR? If you can just give me a thumbs up if you're able to see my screen and able to access the code that is being displayed. Um, Please drop in, you can either react or drop in a yes in the chat box. Perfect. So you all you need to do is scan this QR code or go to the website link being displayed and just enter the code that says U2C0. And you should be able to access a question and be able to put in your inputs. If anybody is having any trouble in accessing the code or the link, please let me know. I can see 3 participants on the link. All you need to do is just type in a word, whatever comes to your mind when you hear about antimicrobial resistance. Oh, I see stubborn. I did not expect to hear that. Microbes on steroids. Cool. Evolution. Candy popping. That's a very interesting one. Let's keep them coming. These are some really interesting terms that I did not anticipate that I'll get to see on this word cloud today. Severe manifestation, superbugs. Okay, somebody has responded in the chat box saying blind antibiotic usage, which is also very relevant and something we'll be pondering upon today during the discussion. There's fear, there is silent clears, there is mutations, deadly mutations. Let's wait for one more minute and then we can proceed with the next segment. Those who have just joined, we are just doing a quick activity where you are just supposed to scan the QR code being displayed over here and enter in one word that comes to your mind when you hear antimicrobial resistance. I like how specific these responses are. Like there is one already talking about rifampicin in tuberculosis. Okay, Dheeraja, you can simply type in your word in the chat box if you are not able to access the link. Almost the end of medicine, definitely. That's that's a really insightful statement and a really scary one too. Okay. Yes. Mm, Thank you so much to everybody who responded. And as you can see, from this word cloud itself, you can have a rough idea as to how widespread AMR is and how multifaceted AMR is. This is exactly why we are here having this discussion today. So now that we know that audience have a bit of an understanding about AMR is, I will just jump to the somewhat of the boring part, and we'll stop this activity now so you can stop responding. Oh, somebody has also entered MRSA. Uh, right. Thank you so much. So these are some of the things that we thought about that medical doctors should definitely know about. That's why two of these organizations are here today, organizing this webinar for you. One is Superheroes Against Superbugs, and other is Global Association of Indian Medical Students. I will just take 2 minutes and briefly talk about what SAS is and what we are doing, and then we can have Dr. Abhishek Kashyap talking about GAIMS and then the panel discussion. So, Superheroes Against Superbugs started as an education and public engagement initiative to raise and promote public awareness about antimicrobial resistance. As you saw that you all being medical students, you are pretty much familiar about what these terms and how widespread AMR is or how complicated this issue is. But the community is not aware about it. That's exactly what SAS is trying to do. We are trying to bridge the gap and inform the public about AMR and let them know how it is not just a concern for the doctors, but also for the public. So we do engage with diverse audience, medical students being one of them, but we also do engage with pharmacy students, with college students, with youngsters, with general people, public, and everybody. We currently have a team of 5 people, three of them being founder members. I think we have Sarah, Panari, and Dr. Samgata, all three of us with her in this meeting, and as well as Dr. Satya and me, myself, Kushi. So we have different objectives. We do take up different ways to promote AMR awareness. One of them being developing innovative and engaging approaches to understand, to enhance the understanding of AMR, to enable young public to advocate for AMR, which includes anybody and everybody. From like it could be a normal high school student, or it could be a very professional student as like you. We try to build diverse partnerships amongst stakeholders and mobilize these stakeholders to in turn then take key actions on AMR. We have so far reached 36,000 plus people, but it is just a number, nothing to do with it. And we have different formats through which we do this. So this panel discussion or the webinar that we're conducting today is just one of the methods, but we do also do actively collaborate with other organizations. We have engaged with our stakeholders via uh, workshops, full day workshops, 2 day workshops. We have developed comics, we have developed infographics on AMR, which are freely available on our website. So if you have time, I would really, really encourage you to just Google SA Superbugs and find out what kind of content we have developed. I would now like to invite Dr. Abhishek Kashyap, who is hosting the session with me and say a few words about GAIMS and then let's see. Over to you, Dr. Abhishek.
Hi, thank you, Kushi, for this kind introduction, and thank you everyone for joining. And I would really like to say that we have a very good audience today. That we have a Sunday evening in India, and people are joining in for this session, and they do understand that AMR is something that we really need to talk about, and uh, and this collaboration with SAS and James has been one such initiative where we really want to sensitize the healthcare workers, especially medical students, who will be the future doctors and taking over and writing those prescriptions. So it's very important for doctors, students to get sensitized about James. Kushi, can we have a next slide? So talking about Global Association of Indian Medical Students, so we were established in 2020 during the COVID era, and now with 5 years down the lane, we have more than 9,000 medical student members, and we can proudly say that we have completed 500 projects, including there are 150 field projects and more than 50 workshops where we have trained medical students into various modalities which would help them in their professional careers. James has this unique agenda where we try to focus and align our goals, our projects with the SDGs 3, 4, and 5, focusing on all these global health issues and considering that our students should also work on these projects and get sensitized on these health issues. Next slide, please. We can proudly say that we are present in more than 20 states in India. And apart from that, we have 6 international chapters where we have more than 3,000 medical students as members. Next slide, please. Our main advocacy focus areas, which we really focus on throughout the year, and we launch various projects and launch initiatives, is about AMR, HIV and AIDS advocacy, violence against healthcare workers, open access to research, gender equity, and global health education. And we also work and sensitize and mobilize our students in case of health emergencies and humanitarian action. So these are the main directions and objectives that keep us going, and how we mobilize our students and train them into such areas. Next slide, please. We have recently launched a nationwide vaccination awareness program for HPV. It is a project that is in collaboration with API India and API USA. So API is the Indian American Association of Physicians of Indian origin. So we have the US chapter and the India chapter supporting us, and we can proudly say that we launched it in the month of January. Until now, we have been able to sensitize more than 1,500 girls in this through this project, be it offline or be it online. We have conducted various campaigns, and we are still working on that. So we have a lot of medical students who are part of James right now in this meeting. But if somebody is not there, if they are interested to work with us, feel free to scan this code, and we'll be sharing the ways to connect with us, our social media handles, so that you can connect and join us in such projects. Apart from that, just I was discussing with the SAS team that we are planning to launch one more nationwide project on AMR, that will be Project Sanjeevani, and hopefully when we have a workshop in AIMS this year in June. So we are planning to launch that campaign, and that will include advocacy about AMR. We'll be working on grassroots level. We'll be working on social media advocacy, and then also we'll be working on the research-based advocacy. So if you are interested in and you're a medical student and you are free to you have that interest in AMR or HPV, please feel to join James. And with now, thank you, Kushi, for this opportunity, and thank you, SAS team, for this wonderful collaboration. Kushi, you can take the floor. Thank you.
Thank you so much, sir. Really glad to see such work being done by medical students, and I hope more students from this session will definitely want to join your course. Now that we have uh, had a bit of introductions, it's time for another game. So before we have the panel discussion, we thought we'd understand what kind of myths there are which are prevalent among the medical students as well, because we at SAS have sort of over the years accumulated a list of misconceptions that are prevalent amongst the community. And I thought it was just a fun way to understand if the medical community also does believe in those misconceptions, or they can spot the lie and call out what's not the case. So this is another game. You might have to just go back to a next QR code. The game is very simple. It's called Two Truths and a Lie. There will be three statements that I'll show you, and you have to pick which one, according to you, is a lie. And that's about it. So again, like we did in the first activity, you are supposed to scan this QR code, which will take you to a place where you can uh, vote for your favorite lie amongst these. Please let me know once you have accessed the code. This will be same throughout. This is actually the same one we used initially. So if you have not closed the tab, I think you can go back there and still see the question. Please give me a reaction in the chat box once you are on the site. And the panelists as well as the team members, please feel free to play the game as well. Okay, this is a 50-50 debate between option A and option B currently. Um, let's wait for 1 more minute for everybody to respond. Right? Many people are calling out option A in the chat box as well. Okay. With this, I think we can end this poll. So nobody believes that antibiotics are effective against common cold and flu, which is good. But doctors do not believe so, but many of the general public, including me, before like 2-3 years ago, used to believe that antibiotics are effective against common cold and flu. But it is a true statement that these are ineffective. If you have a common cold, it's most likely because of a virus. But people tend to take antibiotics when it's a common cold, and that accelerates the problem of AMR. And the correct answer for this question, the lie, is that antimicrobial resistance does not makes your body get resistant to antibiotics. It's the bacteria which evolves and acquires resistance against antibiotics. So moving on to the next question, you can, I think, respond again. Yes, here we go. It says three statements. AMR occurs when bacteria genetically mutates and becomes resistant to antibiotics. Second, AMR has no effect on cats and dogs. And C, superfoods are good for you, but superbugs are not. Please call out the lie. We'll wait for another 1 minute for everybody to respond. I can see a debate between A and B in the chat box. Those of you who are able to, please do respond via the link. It's fun to see the bars going up and down. Shall I reveal the correct answer or are you still responding? As most of you have rightly called out, the lie here is that AMR has no effect on cats and dogs because it does affect animals and humans alike. There is something called One Health, which basically talks about how health is not just human health; it's integrated. There is plant health, there is animal health, there is environmental well-being that comes into play when we are talking about human health. So AMR also does affect cats and dogs. It's not just about humans. And it is true that AMR occurs when bacteria genetically mutates and become resistant to antibiotics. And superfoods are good for you, but superbugs are definitely not because these cause an infection which is not treatable uh, given the existing uh, drugs that we have in the market. Proceeding with the next question, I hope you all can see this on your screen. Again, we have three questions, 3 points, 3 statements. AMR is caused by overuse of antibiotics. B, AMR originates from taking lower dosage of antibiotics than prescribed by the doctor. And C, antibiotics can be bought without a prescription. Please call out the lie from this set. We'll wait for more responses. Many people think that AMR originates from taking low dosage of antibiotics when prescribed by the doctor is actually not a true statement. 50% believe that. Shall we reveal the answer? So the lie here is that option number C, antibiotics can be bought without a prescription. This is actually a false statement because antibiotics are Schedule H red line drugs and they should not be bought without a doctor's prescription. But there is a prevalent over-the-counter sale issue of antibiotics, at least in India, which is not good. This is another misconception that there is that you can just go to a pharmacist and ask for an antibiotic. This is a practice that we should definitely avoid. Moving on to the last two truths and a lie question. let's call the live from this one out. We have three statements again. AMR is caused by overuse of antibiotics. This is it. Thank you so much, everybody who played along. Can I have a reaction of saying if you like the activity? Anything. I hope you all can see the reactions bar in one more section devices. Thank you so much, everybody, for playing along. Now, I would like to start the main segment of today's session, which is the panel discussion. I would like to first introduce Dr. Parth Sharma, who is the founder of Nivarana, which is an online magazine. And he's also an active researcher at Azad, Pune. And he will be moderating the panel discussion today, which is called From Clinic to Communities, What Future Doctors Need to Know About AMR. Good evening, Dr. Parth. It's good to have you here.
Hi, good evening. Thanks for the opportunity to moderate this important session.
Thank you. And before we proceed, I just have one interesting question for you to answer in like 1 or 2 minutes. I would like our audience to know when did you first start thinking about bringing public health and storytelling together? Because that's how Nivarana was born. And was there a particular moment or experience that sparked this idea for you? If you can just answer briefly in 1 or 2 minutes.
So I started writing in 2020. I was doing my post MBBS bond in the Department of Medical Oncology when COVID hit India. And that's when I saw patients suffer a lot because of the lockdown. And that was my first article on how COVID impacted cancer care in India. And after that, I wanted to write a lot of things, and I didn't have the space in media, and newspapers are not accepting everything that I wanted to write about. So I started my own blog called Nivarana, which turned out to be converted into an organization over 3 years, but it started as a personal blog 3 years ago.
So good to hear that. Thank you so much, Dr. Pat. I'm excited to see you moderating this discussion today. We also have Dr. Sonal Saxena with us, who is Director, Professor, and Head at Department of Microbiology, Maulana Azad Medical College, New Delhi. Good evening, Dr. Sonal.
Good evening.
It's good to have you here.
Thank you. Thank you for
I
having me
also
here.
have one question for you to answer before we move on with the panel. What sparked your interest in microbiology, and how has AMR shaped the way you approach clinical teaching and diagnostics? If you can briefly touch upon this.
Yeah, sure. I'm a graduate and a postgraduate from Maulana Azad Medical College, where now I head the Department of Microbiology. And when I was working in the hospital for many things, the internship and my house job, I realized I can't do this first line, this thing. I have to go and work on a diagnostic bench because I was posted as a house surgeon in burns, and burns can be a very debilitating place to be in. And all the time I would see infections. Now I realize they were all Pseudomonas infections, all greenish pus and everything. And I used to feel so sad for those patients that even when we are able to save them, something or the other goes wrong and he used to die or she used to die of infections. So that's what prompted my interest in infections, and that's how I took up microbiology as my postgraduate subject. Talking about AMR, I was introduced very early by my guide. My thesis was on vancomycin-resistant enterococci. And till date, there was no single isolate from India, which was of vancomycin-resistant enterococci. In fact, my thesis was the first isolate which got published from Delhi, where we had this patient of a urology surgery, post-surgery patient. And that's how I started working with, got my interest towards AMR, and I started working with AMR. And later on in 2012, when I got a WHO fellowship to attend this fellowship in antimicrobial resistance in Stockholm, in Karolinska, the institute which decides and gives Nobel Prizes in medicine. That's how the interest developed further. That's all about me.
So good to know that, Dr. Sonal, and you bring in such a rich experience on this important subject. And I'm sure that participants will have really insightful terms really insightful things to hear from you during the course of the discussion. Thank you so much for joining us. We also have Dr. Mansi Malik with us today, who is a scientist at Tata Institute of Genetics and Society, TIGS, Bengaluru. And good evening, Dr. Mansi. I hope you can hear me.
Yes, I can. Am I audible myself?
Yes, you are.
Yeah.
I also have one question for you. What excites you the most about current research, and how does AMR factor into the scientific questions that you are trying to answer? Because you bring in a different lens from all the doctors that we have here. So we would definitely want to hear how did you get roped into the world of AMR, and how do you do it in your daily life?
Yeah, so I work at the Tata Institute for Genetics and Society, as you rightly mentioned, and I started my journey after my postdoc in California in understanding dengue in Bangalore. And dengue in Bangalore was dengue in Bangalore is a concern. And with a lot of meetings with the Special Health Commissioner of Bangalore and the municipal corporation, all of together, we realized that what exists in what exists as the data in the society is not equivalent to the disease burden. And then we realized that doing this surveillance with a molecular lens would really bring about a very positive change, and at least make us know or make us realize what exactly is happening, how much exactly is a disease burden. And this could be, again, not only with molecular lens, but also serologically the data which is available is not properly recorded. The policies are not there. The municipal health associations and such agencies do not know what is happening with the diseases around you. And slowly and steadily moving with such vector-borne diseases, we realize that AMR is such a concern, wherein clinical surveillance of AMR, especially with expertise through a molecular biology side, is really important to convey, or rather to understand or identify the gap, and if possible, fill in that gap. So this is what excites me, and this is what excites me all the more when I talk about AMR.
That's really fascinating. Thank you so much, Dr. Mansi, for sharing your journey with us. Dr. Abdul has not been able to join us yet, but he will be joining us really soon. I would like to request Dr. Parth now to please start the discussion nevertheless, and we can welcome Dr. Abdul as a over to you, sir.
Thanks, Kushi. So welcome everybody to today's panel discussion. I'll start with Dr. Sonal, who is at Maulana Azad Medical College, one of the biggest colleges in Delhi, also the biggest laboratories taking care of patients from all across North India. We'll just start with a basic understanding of what is antimicrobial resistance and what are the factors that are now contributing to it becoming such a huge burden, a public health concern in India. Over to you, ma'am.
Yeah, thank you, Parth. Actually, antimicrobial resistance, is best understood by this thing that it is not very popularly believed that AMR is a very buzzword and we talk about it. What we forget usually is that it is just when the bacteria stop responding to a particular antibiotic. This could happen in two ways. First is that they are intrinsically resistant. That means that they do not have a mechanism which allow the drug to enter or reach their target site, because some of the antibiotics may be protein inhibitors, some are cell wall inhibitors, some work to inhibit a particular ribosome so that the elongation cannot take place for proteins. But they have to reach a particular site to bring out their function. Cell wall inhibitors also have to go inside and work from inside like there are certain antibiotics which work Trojan horse, which go inside and then come and lies the outer boundaries. So what usually happens is that there are two ways. First is that there is a wild type population which simply doesn't allow the drug to enter. Now, for example, Klebsiella to ampicillin or Pseudomonas to ampicillin. They will not, colistin, all the gram-positive cocci. The other is an acquired mechanism which has developed, which is multifactorial, which has developed one due to overuse or overexposure of antibiotics. Like we say, since you're all young children, mom keeps on saying something. Fold your clothes, keep them nicely. Fold your clothes, keep them nicely. She says once, you do it. She says twice, you do it after some time. But if she keeps on repeating it every day, sometimes you reach a stage where you say, okay, it doesn't matter to me whatever she says. And this happens to our students also. You keep telling them, come on time, come on time, come. After a while, you say, this one ma'am is going to say this, let's not. So the same thing happens with bacteria. You keep on exposing it, especially to sublethal concentrations. It starts mutating its genes in such a manner that it's able to tolerate it, or it's able to completely flourish even in the presence of drought. This could happen where you have a kind of a system where it modifies, say, it produces an enzyme which opens the beta-lactamase enzyme. Or it could happen that it modifies the target to which the particular drug is attaching. That is target modification. Or it could be efflux, that the moment the drug goes inside, I open another door and allow the drug to move out of that door or throw it out. So the transporter, the one drug uses one transporter, the other transporter throws it out. So all these mechanisms happen as a result of acquisition of certain genes. And that's why we have a geneticist here on board with us who's going to talk about these genetic mechanisms. And it is these genetic mechanisms which get passed on to their progenies. So, and the bacteria multiplies very fast. Usually the organisms, except for mycobacteria, multiply at the generation time is only 20 minutes. So they double in 20 minutes. So the sensitive ones get killed, but the resistant ones continue to flourish. And that's how the whole population gets replaced. So one is the drug overexposure. The other is the sublethal concentrations. Now, where do these sublethal concentrations come from? One way is that we do not complete our dose. This happens to the best of us. That we are feeling okay after 2 or 3 days and we stop taking antibiotic, thinking that now I'm all right, I should not take it. So it is not misuse or abuse. It is simply giving them sublethal concentrations so that now the drug-resistant bacteria is able to flourish. The other is the hidden amount of antibacteria. Nowadays, you must have seen there are non-vegetarian products which are sold as antibiotic-free chicken. Now, if the antibiotic, particularly vancomycin and colistin, are added to poultry feed to keep them disease-free, because one hen lost is a loss in money to the farmer, poultry farmer. So he uses these drugs in very minute amounts, but so that his poultry remains healthy. But at the same time, what happens is these sublethal drug concentrations keep on collecting within our body. And with every entry of food, they also make an appearance. Similarly, the apple orchards are sprayed with fungicides. They are sprayed with antibacterial solutions. So this is a hidden amount of antibiotic. Then there are so many residues which find their way into the river, the antibiotic residues from the sewage. So that is why this concept of One Health, where we look at all the aspects which are responsible for this, but a majority of which is overuse and misuse by us, the human doctors, rather than, it's very easy to sit here and say that it is all because of agriculture or it's because of the poultry. It's not. Try to ask in honest. I think next time, Khushi, when you have a poll, you should have one question to everybody. How many times have you taken an antibiotic in case of diarrhea without the doctor's prescription? How many times have you medicated yourself with an antibiotic in case of sore throat? Because both these infections usually do not require antibiotics. Sore throats are mostly viral, and diarrheas are mostly, could be allergen, it could be parasitic. They're self-limiting. There's so many things, IBS and so on and so forth. So you don't actually require what to do. So I think you should include these two questions next time when you do the poll, and I'm sure you'll get wonderful, interesting answers.
So like you mentioned, it's a multifactorial problem, and it's difficult to pinpoint one person who's causing this issue. I come from a community medicine background. I see a lot of patients in my community who go to these informal providers because of poor access, and they get medicines and pudiyas in newspaper packets. And most of the time, there is one antibiotic in that, and they get 3 doses, 4 doses. So again, like you mentioned, inadequate or low doses of antibiotic being given to patients. Another emerging issue which I've noticed is poor quality drugs, so not of standard quality antibiotics, which say 500 on the packaging, but you never know how much is inside because of poor regulation on our quality of drugs. So multiple issues, and it's becoming a bigger and bigger problem with each passing day. Dr. Mansi, I'll come to you after this. as you are a scientist, how are you tackling this issue of antimicrobial resistance, and what role do scientists play in this?
Yeah, so it was a very good introductory kind of question for Dr. Saxena, and she answered most of it, to be very honest, because there is a lot of problem, not only restricted to clinical settings. There's a lot of problem of AMR which lingers around us. Talk about the environment, talk about the poultry, talk about soils where people are people are growing, the farmers. It's too much out there. So basically, what we are doing, or what researchers are doing, thankfully, AMR is something which has been taken up quite a bit now for research, and many people are trying their own ways to try and mitigate AMR. Uh, in my lab, rather, or as an institute, we are mostly focused on surveillance. We do environmental surveillance, wherein we look at the sewage, outlets in a city, and look at the signatures, the antimicrobial resistance signatures in the water. We find out a crazy amount of colistin resistance. We also find out resistance to your disinfectants, which are usually used in hospital settings, and it's really crazy. Like, okay, if you have bugs which are even growing on a sanitized, surface, or a sanitized, something which is resistant to such sanitizers as well, where would you go in the coming future? Then again, we are not restricted just to environmental surveillance. We do a lot of clinical surveillance. We literally have hospitals wherein we go and there are many samples, which come as when you do a routine culture methods to grow the organisms in a clinical samples. And most of the times it takes a lot much time. It is sometimes, anytime you take a swab and you want to grow a bacteria out of it, it takes minimum 3 days to understand what the pathogen is, right? And it is very so it is okay if the patient is healthy, and you can stop or wait for that 3 days for a proper antibiotic treatment. Most of the time people start empirical treatment before even giving the swab. So that is okay for people who are in a healthy state of life. But people who are in oncology wards, or people who really need fast track decisions to be made of what antibiotic to be given, the routine cultures are time consuming. So as a part of our clinical surveillance branch, we have also ventured into molecular diagnostics, wherein thankfully with COVID, PCR became a very household name. And we knew PCR exists since like years now, and we just used it for COVID, and RT-PCR became, CT values were discussed on the dinner table. But there are bugs, there are bugs which you can detect early using PCRs, and you need not have, and these assays should not burn a hole in your pockets. So that is what we are interested into as a part of our clinical surveillance initiative. We are also building some molecular diagnostics, which we want to give the hospitals and the public health centers to try on to capacity build, so that such assays can be easily used to detect the pathogen A, such that exact treatment, the exact antibiotic could be prescribed. That is one initiative that we are taking from TICS. The other thing which we are working on is we are also working with veterinary institutes, and we are also trying to look at the AMR signatures in there. Like, what are the different antimicrobial signatures existing across poultry, across cattle? And the other thing is we are also looking at soil surveillance, like what is happening to some patches of soil near when you have a lot of orchards, or you have a lot of vegetation happening. So such activities, and we are not restricted to just one method. We do a lot of genomic, we do a lot of whole genome sequencing to get those answers out, so that metagenomics enabled molecular diagnostics could come into picture, and the difference between this could be the pathogen to this is the pathogen could be achieved. So these are our research initiatives right now.
And just to follow up on that, do you think it's more like an urban issue or a rural issue when you and all your surveillance and tracking? What does it tell you?
So right now we have seen, at least I have been doing, and what my colleagues who are doing environmental surveillance are doing, are basically in urban population. We are seeing that in urban population, I have a very small village near Tamil Nadu who I work with, near the Kaveri Delta belt, and I see a lot of AMR even there. So, but it's just preliminary, so we are just waiting. But we are going to expand in both. It would be two ways: rural versus urban, as well as community versus different communities in a particular urban and rural setting. So this is what we're working on right now.
And just another, out of curiosity, do you think it's the burden is same inside the hospital and outside the hospital? And maybe Dr. Sonal can also pitch in here, because when we think of AMR, we think of it as an issue which is seen inside the hospital. And when I go to communities, it's often difficult to explain to them how AMR will impact them, because they think this is an issue of the hospital. So do you think when you do tracking and surveillance, are you finding similar patterns of resistance in communities as well?
I can briefly tell you about, we have seen signatures of a community. We have seen rather equal signatures of, it's not very different from what you see in a hospital setting. That's what is observable in my or our collective data analysis. But this could vary because we have just been restricted to Bangalore and a few places in Tamil Nadu and a few places in Bhopal. But as and when we are expanding, we are seeing that things are not very drastically different. Actually, people who come to OPDs do not know that they are having such resistance in there, because when you do a random survey, when you do a clinical random survey and you do a NGS and you understand, okay, they have these signatures, it's kind of scary. Yeah.
Thank you, Dr. Mansi. We also have Dr. Abdul, who has joined us now. Dr. Abdul is a senior consultant and adjunct professor in infectious disease at Apollo Hospital, Chennai. Welcome to the discussion, sir. We already started the panel discussion. We have had a couple of questions. I just wanted to jump to you straight now and ask you, how do you think AMR impacts patients when you see patients inside your hospital? And could you tell us some examples from your clinical practice where you've seen AMR impacting people?
Thanks, Parth. Good afternoon to the audience. I treat the most vulnerable group of patients because 90% of my work as an infectious disease physician is in oncology setting. And cancer patients are the most immunocompromised patients you can come across. And cancer patients are the highest risk of carrying drug-resistant bacteria. Because by the time they come to your hospital, to a tertiary care cancer center, they visited many other doctors, many hospitals. So even at the time of the admission to a tertiary care cancer center, by that time, they will be carrying drug-resistant bacteria in their gut or on the body surface. So you start with drug-resistant bacteria when you initiate, by the time you initiate chemotherapy. And then due to chemo, the count drops, the immunity drops, they develop infections, and after week, and many people like leukemics needs several cycles of chemotherapy. And after every cycle of chemotherapy, there's a risk of infection, and many of them develop infection. We give a course of antibiotic, again the next cycle, so they develop resistance further. So I would say a large percentage of the cancer patients in tertiary care centers are carrying highly drug-resistant bacteria. And you know that from data, global data, our own data, if a patient is carrying carbapenem-resistant bacteria, the chance of that patient's high morbidity and mortality is significantly higher than patients with drug-sensitive bacterial infection. The AMR is real. And if you want to see the real show of the performance of or danger of AMR, come and see the cancer patients. Where it's not AMR, people call it's a slow pandemic. It's not a slow pandemic. It may be a slow pandemic in community or ordinary patients. But with immunocompromised patients, you can see that in front of your eyes. Have you seen Pseudomonas developing resistance? In front of your eyes. Severe Pseudomonas infection, you give one antibiotic. You will see that within few days become resistant. Give the next one, become resistant. The next one become resistant. But I'm talking about a very, very focused, concentrated population. So it's not a silent pandemic. It's a real, live, overt pandemic.
Thank you, Dr. Abdul, for that. And as soon as one resistant organism develops, and everybody is at risk. It's not just the immunocompromised people, but that vulnerable population is definitely more at risk, like you mentioned. Dr. Sonal, I'll come back to you. Since you're working in one of the biggest hospitals in, I would say, North India, and one of the biggest hospitals in the country, what is the trend of AMR that you have noticed in your lab samples that are coming to you? And are there any antibiotics which don't work anymore that you have noticed?
I will not say they don't work anymore. More than the hospital, I'm also looking after a network of antimicrobial surveillance for 24 laboratories, which we started from our association's Delhi chapter, the IMM Delhi chapter, and which I continue to be the nodal officer for. And there we receive data from 24 laboratories across Delhi NCR, from Noida, from Gurgaon, from Delhi. It's a mix of public and private hospitals. They are mostly tertiary care centers, except for one center, which is a standalone diagnostic center. Now, that standalone diagnostic center caters to both. It doesn't cater to admitted patients. It caters to the population which usually walks in client, or, they want to get something tested. They want to a practitioner and he says, get your culture done. So it's that data which comes actually from community. It's not one of those multi-exposure data. And very often I've tended to compare that center's data with the remaining 23, and I realize there is not much difference. So the resistance to the first line drug, the tier 1, as the CLSI or the clinical lab standards from America call it, is mostly 60 to 70%. The methicillin resistant staph aureus rates, which is one of the huge markers used in the West to monitor resistance in gram-positive organisms, is almost 60%, even in the national data, the ICMR and the NCDC network, and we get a similar picture. Now, like Dr. Abdul Ghaffur was saying, the problem with the tertiary care centers is that not only do we have a patient who's been exposed to multiple antibiotics, but also a patient who comes in at the last stage mostly. So Mansi is not going to reflect any data which is of community. It reflects the data where it is more tertiary. It has a more good amount of healthcare associated infections component. So they will be from a more resistant clone of bacteria. And it also brings about a lot of patients who are not treated outside. They come to this tertiary care center that, okay, we are, let's go to LNJP or MAMC where we, treated better. But the issue is that our data I have seen completely aligns with the national data. So there's the amount of resistance that is there sometime back, colistin resistant Enterobacteriaceae was a rarity. We used to get 1 or 2 isolate a year. Now my PhD student is doing work on colistin resistant Enterobacteriaceae and Acinetobacter and Pseudomonas because we get these many isolates. So you can see the picture now. 4 years back before COVID, or maybe even 21, 22, if you had asked me, I couldn't dream of giving a work on colistin resistant organisms. And we do the broth microdilution, which is considered the gold standard. We are not following an automated or any other platform. So one is this. The other is that many times I've realized that the results, even when people then they bring the results, they are not very quality assured results. So that is another thing which I always feel that microbiology labs should always have a quality assured data. Whatever you are sending out, you should be very sure about it. And the third component is, which I think Dr. Abdul should elaborate more upon, is the infection versus colonization. A lot of the time we find that we get an isolate, but it may not be causing an infection. It may just be a colonizer, and because the patient is admitted in a hospital, that colonizer will be a multi-drug resistant colony. So it's a reality that MDROs are there. It's not less, it's not more, but they are there. Almost 1/3 of the population is MDRO in the hospital.
So just to follow up on that, since it's such a major problem, then what is the role of culture sensitivity testing? Does every person who's coming to the hospital require the test, or how do you decide who needs that test?
See, actually, the thing here is that when we have an antimicrobial testing laboratory, one is that the lab should be there. Most of the peripheral and even the district hospitals, unless and until they are now converted into a medical college, usually do not have facilities for this. And in my journey into this network in the past 5 years, I realized that even we had to train these people. They were from one of the big names of private hospitals, but we had to train these people into many facts. That how to store your discs, how to keep, a track of your incubators. So quality becomes such a huge issue, even if the lab is there. The important question is, how does a clinician decide that this patient needs a culture or not? So every patient where you need to prescribe antibiotic, ideally the culture should be taken before the start of antibiotics. Now I understand if a patient has got a meningitis, it's a life-threatening situation, you may want to start an antibiotic first and then take your time to do an LP. But for the remaining, even if it is sepsis, UTI, sample should be taken first for culture and sensitivity before the start of antibiotic. And even if antibiotic has been given, then try to take the sample before the next dose is due, at the time where the antibiotic concentrations are very low. Because what happens is, even a single dose is sometimes, especially body fluids, it's able to sterilize the whole sample and you will not get anything at all. The third is the collection and transport procedures are also needs to always be reminded to our clinicians, that the collection should be appropriate container, appropriate storage, how to transport, when to reject. All these become very, very important things when we are reporting the sample. And it also helps us to find out that, yes, this is not a pathogen, but probably a colonizer or a contaminant or, just a bystander who's we are reporting. So to take those decisions in the lab, we require certain information which needs to be given. But yes, a culture sensitivity lab is a must for all the hospitals, and it should not be outsourced. It should be within the campus, and it should be, giving you quality assured results.
So that clearly highlights the need for infrastructure building as well in the public health sector. And also you have highlighted the role that doctors play or people who are collecting the sample play so that the right information is ultimately communicated for patient care. So the method of collection of sample is also extremely important. I'll come to Dr. Mansi now, hoping that we'll get some hope from your side. Is science progressing? Do we have any new ways of addressing AMR? Because from what I understand from pharma economy, the pharma industries are not very interested in making antibiotics, because what's the point of making an antibiotic? Because the bacteria will develop resistance and the whole infrastructure has gone to waste. So do we have any other progress in science? Do we have hope in the field of AMR?
Yeah, there is quite a bit of activity happening in the research area for developing some solutions for AMR. Like antimicrobial peptides is something which is very keenly being worked upon. Many major institutes in India are working on developing new antimicrobial peptides. ICMR is also supporting quite of this research of developing new antimicrobial peptides. Another research which is happening is in CRISPR. With the gene editing technology, people are trying to make or edit this, multi-drug resistant organisms, and they are trying to, make them more, some knockouts, knock-ins, and so that they can be spread into the population. So with CRISPR, or rather active genetics, is one of the approaches which was tried very recently in 2 to 3 years back by a US based lab, and I think that is something which should be tried out in India as well, and which would bring some hope. Phage therapy is something which is which holds a lot of future, wherein you have bacteriophages which can be given in place of antibiotics, and this phages could actually help. And there is a company, if I'm remembering correctly, it's Vitalis, and there's one more company, a startup which came in Bangalore itself, who are trying to do some research, or trying to get this phage therapy commercialized. The other progress which has happened, on which exists in some hospitals which can afford it, is having a multiplex PCR panel, wherein you can immediately in 1 hour, 2 hour detect what pathogens you have and what antimicrobial resistant genes you have. But this biofire panels, as they have been called, they actually are very expensive, and they actually burn a hole in your pockets. So cost friendly or cost effective multiplex PCR panels along with ARGs are getting developed. More and more startups are coming into PCR based diagnosis, affordable PCR based diagnosis, to get this pathogen identification and ARG identification more affordable. So these are the different activities which are actually, which hold hope. And actually, also one more thing to add on is with the revolutionization of the next gen sequencing, with the metagenomics data, when you sequence the entire sample, you absolutely know, what genes are present, what is this variation in the particular bacteria which is there, and you can absolutely design your assays based on that metagenomics, and which would be a game changer for early diagnosing some of these infections.
Thanks, Dr. Mansi. Uh, it clearly looks like science is progressing, but coming from a community medicine, preventive medicine background, I feel we often forget the role social determinants play in even in AMR. It's well known that people who come from the manual scavenging background are more exposed to AMR. People with malnutrition are more exposed to infections and thus AMR. So again, I hope our policymakers and people working to tackle AMR also keep social determinants in mind while addressing this problem. Dr. Abdul, my next question is for you. Now that we have learned a lot about AMR, how does one protect themselves from AMR? If I'm going into the community, how do I counsel or educate the community members of how to protect themselves? Are there any preventive measures that people can take to safeguard themselves?
How to prevent AMR in the community? It's a very interesting question, but it's very complex to answer that question, because the antimicrobial resistance is a complex, very complex scientific, socio-economic, and political challenge. Because it's not just overuse of antibiotics by doctors or patients or in veterinary. It's closely linked to the socio-economic factors in the community, especially the sanitation issues in the community. One of the main reasons how drug-resistant bacteria spread is inadequate infection control standards in hospitals and inadequate sanitation in the community. If you look at the South Asia and Mediterranean countries like Italy, Greece, both these regions have got very high carbapenem resistant gram-negative rate. But in India, in South Asia, not just India, South Asian countries, this bacteria is prevalent even in the community, while in Mediterranean countries, it's less common in community, but equally common in the hospitals. That's because the community spread is directly proportional to the sanitation issues. And in our country, or South Asian countries, we have got a huge sanitation problem in most part of the region. And the bacteria spread in the river, in the water, in the community, especially the water, because the most important group in the resistance perspective, the Enterobacteria, like E. coli, Klebsiella, living in our gut. So better sanitation, better hand hygiene, hand washing. I'm talking in the community. That's the best way to prevent you from getting drug-resistant bacterial infection in the community, because that's how you get it. And then only I'll put don't use antibiotic unnecessarily. Of course, then you use antibiotic, you have a chance to develop resistance to that antibiotic. So don't take antibiotic unnecessarily, and don't ask your doctor to prescribe antibiotics. You discourage your doctor to prescribe antibiotic. Ask your doctor, Doc, do I really need antibiotic for this infection? Because why should we ask a doctor, will your doctor prescribe antibiotic unnecessarily? It's true that the patient pressure is one of the most important reasons for antibiotic unnecessary usage, not just in India. This is the UK data I'm quoting. 50% of the antibiotic used in the GP setting is because of the unnecessary patient pressure on the doctor. It's behavior, it's psychology. So don't take antibiotic unnecessarily. Don't force your doctor to give you antibiotic, and much more important, sanitation. And just let's not forget that antibiotic resistance, one of the main contributing factors is growth promotional usage of antibiotic in the community. The poultry farming, the animal farming. For example, I'm sure all of you heard about the colistin resistance. I would say if you look at the colistin resistant prevalence in major Indian hospitals, they were really increasing until 2018. Step by step, every year, he plot a graph, increasing almost all major Indian hospitals. But then after 2019, there was a gradual drop in colistin resistance. There was a rapid increase. Now there's a significant drop. Until 2018, I used to see a colistin resistant bacterial infection at least once a week. Now for the last 2-3 months or 4 months, I haven't seen a colistin resistant bacterial infection. It's become very less common, not only in my center, I'm sure that's the data in most centers in India. Why is that? Am I not using colistin? Still in my patients, I use colistin. I treat the most immunocompromised patients. I use a lot of colistin. So why did the resistance drop? That's because of, in 2019, our country banned growth promotional usage of colistin in the poultry farming. You may ask me, what is the relationship between antibiotic use in poultry and in humans? If you look at that, the amount of colistin used in poultry farming, growth promotional, for the sake of medical students, I will tell you, farmers, poultry farmers and organized cattle farmers add antibiotics in the feed to make the animals grow fat and fast. That's called growth promotional usage. And colistin was one of the most popular antibiotic in India used for farming. If you look at the volume of colistin use was 20 times more in animal growth promotion than in human for treating infections. And more than that, you know how much colistin they add in the feed? 5 grams in 1,000 kilogram of feed. 5 grams in 1,000 kilograms of feed. Such a low, tiny quantity for prolonged until the chicken is killed. Weeks and months at a mass level, the whole farm is on colistin. That creates large amount of colistin resistance in the poultry, and that we eat it. It's spread into vegetable through poultry litter, because poultry litter is a manure that's spread in the community. That India banned in 2019. And 95% of the colistin as a growth promoter was imported from China. And because of one ban, the import stopped. So in my opinion, the most effective policy by Indian government is the colistin ban. Why is most effective? Let's look at the national action plan, state action plan. In a large country like India, it's difficult to implement any policy. We make policies in Delhi, but implement in a country of 1.4 billion population, more than 35 states, it's very difficult to implement. But colistin ban was a central decision, and import stopped, got implemented. And that made a huge difference in colistin resistance in India. If you look at the molecular pattern of transmission of colistin resistance from poultry to human, it's very interesting and something that is proven, that level of transmission. So the question of how can we prevent ourselves from getting resistance, that's why the answer is very complex. But we can do what we can do at individual level, as a medical professional, as a public health professional, and a citizen.
Very well, in detail you have explained. I think to summarize it, like you mentioned in the end, it's at the individual level, community level, and then national level. So at the individual level, like you mentioned, hand washing, sanitation. Community level, maybe asking your doctor not to prescribe antibiotics, more awareness in the community. National level, like policies you mentioned. Just to tell the audience also, there was a study in which they found that 1 kilogram of chicken has 148 milligrams of antibiotic. And the safe limit is only 2 milligrams. So even a lot of chicken that people are eating has a lot of antibiotics in it, which is also causing AMR. My final set of questions is the same question for all three panelists. We have an audience of medical professionals today, and so I would like to ask each one of you, if in 2 lines you had to summarize what is the role of medical, paramedical professionals in addressing this threat of AMR, what it would be as per you. I'll start with Dr. Sonal.
Only one set of advice for prescribers.
I think otherwise this will go on for another. It can be a 2-day conference otherwise.
I know. I just want, the prescribers. I always say this in all the meetings where I have potential prescribers and prescribers, that you should have faith on yourself. Just don't hide behind antibiotics. It's very easy to hide behind any drug. We were in a meeting with DG sir day before yesterday, and he said that I saw a prescription which has 22 medications. Now, what are 22 medications doing on a prescription? And then he took us through those 22 medications, and we all had a good time laughing over it. So every practitioner needs to perfect their art. You are perfect in your art of treating that patient. Your skill set is made like that. You've worked really hard to reach that skill set. Now, trust that skill set and treat your patient. Take a very rational decision before you write an antibiotic. Can I see this patient maybe after the investigation or maybe after the test? get a rapid marker done like a CRP or a PCT. If you feel that still it could be a bacterial, but don't start antibiotic just on the fly. And don't get into this rat race that if I don't prescribe, people will not come to me. People will come to you. You're a huge, multi-talented prescriber. You really slogged your way to become a medicine. NEET is labeled as one of the most tough exam all over the world. You cracked it twice. By the time you become specialist, and people like Dr. Abdul cracked it thrice. So have faith on yourself before you prescribe antibiotics.
Thank you, Dr. Sonal. Dr. Mansi, what would your suggestion be?
I agree with Dr. Saxena, absolutely. But I would just reframe it into, because I'm a doctor who does PCR and not CPR. So I would rather say that, as ma'am said, we need to know the cause, what is giving you the disease, basically pyrexia, fever of unknown origin, is something which pushes to AMR all the more. If you are having a viral fever, you need not pop in an antibiotic. Azithromycin became a Hajmola candy for people during COVID, right? Everybody's popping azithromycin. It doesn't work for majority of people now, and which is not good, right? So identifying or diagnosing the cause, or having early, rapid, sensitive, and affordable diagnosis, prioritizing early diagnosis is something which I would like to mention profoundly.
Thank you. Dr. Abdul?
Yeah, I would say antibody resistance crisis is not because of the irrational usage of antibiotics by doctors. It's so complex. There are the role of public, the role of veterinarians, the role of socio-economic political system in any country. So we doctors should not carry that guilty feeling. We, the doctors, are the one creating antibiotic resistance. No, but we are making our significant contribution to the complexity of the problem. But we have a bigger responsibility. We, the doctors, are the one witnessing the death and suffering of our patients because of antimicrobial resistance. So we have of course, rationalizing prescription is a responsibility, but much more than that. We are the people who should lead the fight against resistance. It's our responsibility to convince and mobilize all the other stakeholders to act against antimicrobial resistance crisis.
So it sounds like everybody's saying the same thing, where it's a lot of awareness, both in the medical community and our general community, and followed by a lot of action following awareness. Action in this case being don't take any action, rather than taking action of prescribing antibiotics. We can open now for the audience questions. If there's anybody in the audience who would like to ask any question from our experts, please feel free to either type your question in the chat box or unmute and ask.
I can have one question. Does vaccinations help in preventing AMR?
So, role of vaccines in preventing AMR. Dr. Abdul, would you like to take that question?
Yes. Vaccines play a big role in preventing antimicrobial resistance, whether it is vaccines against virus infections or bacterial infections like a pneumococcus or virus infection like flu. The more population you vaccinate, the less prevalence of bacterial and fungal infections. The less prevalence of infections, the less antibiotics you need to treat. It's a proven concept. Vaccines play, that's why in any antibiotic policy we prepare, we give a very good importance to the vaccination at national level.
And for example, typhoid has a lot of resistant strains in Delhi, and which is why the Delhi government is providing the typhoid vaccine, which is not there in a lot of states. 2 years of age children in Delhi get the typhoid vaccine. So there's another comment. So next time I see someone with fever and few general symptoms, what is the sequential steps that I should take, and at what step should I prescribe an antibiotic? I think again, Dr. Abdul.
What is the question, Parth?
So if somebody comes with fever and few general symptoms, what sequential steps should a doctor take, and what should be the point of prescribing an antibiotic?
Right. It's again a complex question, but we all doctors come across this probably 40, 50 patients a day. take a detailed history. From the history alone, you will know you'll be able to differentiate between a virus and bacterial infection to a great extent. Do a proper clinical examination. Do proper tests like a complete blood count and basic investigation. I would say 90% of the cases you can differentiate between bacterial and fungal infection and avoid unnecessary antibiotics. I would say in 10% of the patients, however good you are, without waiting for the culture results, you won't be able to differentiate a bacterial and fungal and viral, and you may have to prescribe an antibiotics. So be a good clinician to the best of our ability. Not all of us are great clinicians, but we all can improve ourselves by following the available guidelines and talking to our own community friends.
So what I usually do in the community is, because it's the benefit of working as a primary care practitioner, you can always call them back at day 3. If you are too much in doubt that they are too sick, and you're on borderline whether it's virus or bacteria causing this, just start with conservative management, call them back in 2nd day or 3rd day. If they are worsening, then probably they need an antibiotic. If they're getting better, it's probably viral. And that's what I follow in borderline cases when I'm not really sure based on history and examination whether it's virus or bacteria. Dr. Mansi, next question I think you would be able to answer. Can we reverse antimicrobial resistance like penicillin resistance? Is there anything that can be done?
There have been studies by a pediatrician in California, wherein they have tried to reverse the antibiotic resistance. They have tried it for penicillin, they have tried it for azithromycin, and it shows promise. The only problem that they have done it for a few clinical setups. They are in a I have met that pediatrician, fortunately, and we have discussed this, and we would definitely, start working on something like that. There are certain mechanisms. There is some amount of research that goes into, how can you repurpose antibiotics rather than using the term to reverse the resistance. Can you repurpose the antibiotics which you think will not be effective against this particular condition to be reused? So this is something which is in the pipeline, at least for us, that we are working on it. And the other thing is that microbiome is basically researched upon a lot, that, there is something known as hyperstimulation of the microbiome. Some microflora can be increased, which can help, reduce the drug-resistant pathogens in the gut and stuff like that. So there are ways and mechanisms not out yet openly in the practice, but a lot of things would come very soon handy to the doctors with the way the research is progressing. I'm sure about it.
Thanks, Dr. Mansi. Dr. Sonal, there's one question for you as well. How can future doctor approach AMR in the case of emergency? You briefly mentioned it in case of meningitis, but when people are working in the emergency department, how would you advise them to approach prescribing antibiotic or AMR?
See, in an emergency situation, like I gave the example of CSF meningitis. Now, every hospital should have an empirical antibiotic policy. And if they don't have, there are set antibiotic policies which are available from NCDC. NCDC currently is in the process of revising their national treatment guidelines, and very soon you will have a new national treatment guidelines. On the other hand, there is an ICMR antibiotic prescription policy. So in case you don't have something specific to your hospital, you can always take help of that. And based on that empirical antibiotic policy, you treat your patients in the emergency depending on the conditions. And like I said, there are certain, rapid tests like the PCT or CRP or maybe even a CBC gives you some idea as to how sick the patient is and how it should be taken care of.
Thank you, ma'am. Dr. Abdul, there's one question for you. What to do if a patient is resistant to most antibiotics commonly prescribed? I'm sure you see a lot of such patients in your practice. So what do you do when you face such a situation?
Yeah, I see such patients, a lot of such patients, my oncology infection practice, where nowadays you see, because we have new antibody like ceftazidime, avibactam, and a few more antibiotics are available. And nowadays, I rarely see pan-drug resistance, especially because of colistin resistance have significantly dropped. So at least 1, 2, or 2 antibiotics are effective in most of my patients with severe infection. And that is a lucky scenario. And earlier, we used to see pan-drug resistant, not even one antibiotic is effective, including colistin resistance. And at that time, ceftazidime avibactam was not available. But still, having 5-6 antibiotics in your hand to treat an infection, to choose one of them, and having 1 or 2 antibiotics, and you have to use any one of them or one of the other is a difficult choice.
I also agree with you, Dr. Abdul, on this, because very often we see very, very sick patients who are admitted in our ICUs, particularly kids. And there you find either if they are resistant, even if they are resistant to colistin, we found them to be responding to the newer ones that we are testing, either ceftibactam astronam combination or the metazectum combinations. But my only
There's some internet issue at Sonal site, I think. We'll just wait. Till then, I'll ask Dr. Mansi. There's one final question in the chat box. Where is the world headed? Considering you are tracking this AMR in the community, in hospitals, where will we be 10 years from now? How will antimicrobial resistance evolve? And what kind of impact should we anticipate?
Well, as Dr. Ghaffur said, that it is not a silent pandemic anymore. It is out there, and I'm very sure the scenario that he sees in his oncology wards are more frightening than ever. AMR is slated to grow because still a lot of efforts for outreach and are still needed. We have not even reached 1% of what we should do for outreach, and for there are many hospitals who don't even know that there are faster or sensitive methods, or there are faster or sensitive areas wherein you can do certain things in a different way, and you can you can absolutely take care of patients. There's so many deaths happening due to AMR. uh, I have been a part of a few because of my hospital collaborations, and I've been working with critical care consultants, and when I go for these meetings, when there is an AMR death consortium meeting, it is scary. It is, for me, it is really scary. And when I look at the data analysis of a community based, people who come with acute febrile illnesses, and I look at their data as compared to, I compare the data from a hospital, from an ICU ward, and from a normal tertiary care hospital. The signatures, there's MRSA there in the community. There colistin resistance in normal wards, which you find and which really go unnoticed. So it's not very, we are not in a very great place with AMR right now. And if we do not take really serious actions, we are not heading towards a very good way towards AMR. It's slated to increase if we do not take charge uh, right now. So we cannot wait right now. It's really there, and I can only imagine the cancer, how it is happening, and it is worse in a pediatric ward also. It's horrible. So I mean, yeah, we are not heading towards a very good place in the coming years if we do not take action. That's what I would like to conclude.
And world peace is equally important for AMR. There is a paper which came out in Nature which highlighted how the Ukraine war has actually contributed to the spread of AMR globally because of migration of the refugee population now. So all the wars are also in a way contributing to AMR and its spread. Dr. Sonal
I'll just talk about typhoid because I've been working. I'm sorry. Is it for me or?
No. Because Dr. Sonal has joined back and she was saying something before she lost connection. So I just wanted her to complete.
No, yeah. Actually, what I was talking about was see, in my experience in the past 5 years network, I've realized that the patterns have almost remained same only. We were saying 55% of MRSA, now we are seeing 60% of MRSA. So it's a very slight increase. But just imagine this after 20 years or after 15 years or after 5 years. Where this figure, if it is increasing even 1% a year, in the next 20, 30 years, you crossed 100. That means everything is it will end up as a pan-drug resistant unless we take some action. That is what I was saying. And the other thing that I had something in mind which I was putting forward, that when you talk of repurposing an older antibiotic, in my experience, they don't work very well. Suppose the clinician stops prescribing Septran or cotrimoxazole, and then it comes back and makes a comeback, and you see a lot of sensitive strains. But within a few months, they start again becoming resistant to it. So once they have that mutated gene, it's going to stay. It's not possible to remove that gene due to this, and that population multiplies. Especially aided by the sublethal doses, it tends to multiply. The mutant window, as we call it, in the microbiology testing. One more thing which I have seen in my own practice is, everybody talks about enteric fever. Everybody talks about enteric fever, and that is one area where the antibiotic is completely misused. Because what happens is that the Salmonella typhi, there are breakpoints for azithromycin, and there are breakpoints for ceftriaxone and cefixime and everything. But we see a lot of paratyphi A and B also, A particularly, paratyphi A in our laboratory, and there azithromycin should not be given. But a pan drug, people are treating at home enteric fever, whereas now it doesn't respond to, it may or may not respond to azithromycin. It may be simply paratyphi A. So that kind of a misuse, should be stopped. Why are you treating enteric fever on empirical therapies beyond my understanding? I myself had this infection last year. It's a very debilitating infection, and it requires a very thorough clinical examination, and it grows in blood culture even after a dose of antibiotic. I have seen in many cases. But the reliance on Vidal, the reliance on poor quality blood cultures makes it very, very difficult for clinicians also to treat, because then it becomes an emergency and it's a killer. So I think that is one area where, a lot of prudence should be exercised, and the culture of culture should be built in. The moment you suspect enteric, get a blood culture done. How many days of fever it is, doesn't matter. Only if you remember those diagram, now I edit the Anand Narayan book, and I realized that that diagram has stayed with the book for many years. It never says that after first week the culture rate will go down. It says only it comes down a little. It doesn't say that in the second week of fever or third week of fever you will not have the organism growing in culture. You will. Only the sensitivity of the test becomes slightly less. That's what I was saying when I got logged out. I'm so sorry.
Thank you for highlighting that, because Vidal as a test is, I think, the most one of the most useless tests which exists and is most overexploited test in the community. Everybody with a fever gets a Vidal done, and they come to our centers with antibiotics. So I think like this has already been highlighted, capacity building in laboratories and tests for blood culture being able to be done at centers, but also knowing how to interpret Vidal, because Vidal test is also not standardized. What antigen cutoffs there come positive, we don't know. So it's often two tests which need to be followed up, and Vidal itself, I think, should be off market. Because it doesn't really help in the clinics. I think there's one final interesting question on climate change and AMR. Dr. Mansi, it's addressed to you. How does climate change impact AMR, and is there any overlap in this area?
I mean, that's a very interesting question, and this question comes a lot wherein, with the rising temperatures, with so warmer temperatures, we all know that, warmer temperatures would you actually help in growth of these organisms faster. So yes, there is with the rising heat waves coming in through with the climate change, the prevalence of these organisms and infections increases with like rains. There are a lot of vector-borne diseases increasing. There are a lot of other diseases increasing, which would give you bacteremia, which could give you infections. And again, displacement is a major factor wherein with climate change and with population mobility, you carry infections with you, like paratyphi, as ma'am was mentioning, paratyphi A, paratyphi, Salmonella typhi, and paratyphi A are very common, but paratyphi B is not very common. But if you look at the the refugee population as such. We have seen remnants of paratyphi B. So very, very rarely we have seen paratyphi B up and down being observed in the clinics or in CMC Vellore especially. We have seen paratyphi B coming in over. So these are the factors, which could absolutely increase the rate of AMR. And advice as such, we cannot control the climate change, but only thing is we can control the way we deal with it. So as all the other two doctors have also mentioned, Dr. Saxena and Dr. Ghaffur, we need to be just very careful and take these points which they have mentioned in the entire session, that and again, also one more point of what I mentioned was prompt decision making and prompt accurate diagnosis could also help in trying to mitigate this problem. So we cannot control the climate, so that's why we control our
Exactly, yeah.
decisions.
Sadly, a lot of things are out of our control. There's only little we can do. Thank you to all the panelists. This was a very interesting discussion. I personally learned a lot, and I'm sure our audience here today also got a lot of new insights on AMR. I'll hand it over back to Khushi now to take the discussion forward from here.
Thank you so much, Dr. Parth, Dr. Sonal, Dr. Mansi, and Dr. Abdul, for such an insightful discussion. A lot of new things for me also to learn, and obviously there are certain things that keeps coming back whenever we have a discussion about AMR, be it like patient pressure for prescribing antibiotics on the doctors. This is one of the most pressing issues that we keep getting on again and again after we conduct our AMR frontline workshops and we visit medical uh, hospitals and medical colleges. And obviously, community engagement and community awareness about AMR, how it is not just your consumption of antibiotic which is leading to AMR, but also how the food that you are eating or the environment that you are living in, it also has antibiotic resistance gene, which accelerate the problem to a great extent. Thank you so much for giving us a broad overview and putting the picture out there as to what this is and what we can as a community do to tackle this. Thank you so much once again for such an insightful discussion. I hope the audience also enjoyed this and had some meaningful insights to take away from here. Uh, Thank you so much. Now, actually, we do move on to the next segment of this panel discussion, which is we thought we can just do a quiz to end this today's session to analyze how our audience gauged on these concepts and what uh, they understood from it. So this is perhaps the last second QR code that I'm asking you to scan, but please come here. I'm also dropping the link in the chat box. There are a few fun questions that we can answer together and see what all we did done. Please give me a reaction in the chat box once you have logged in. I'd really like to thank our panelists for taking time out on Sunday and coming here and spending this time. This was really, really great. Thank you so much. I hope you all can see my screen and are able to access the link as well.
Yeah, we can see the screen.
Okay. Okay, I can see two participants join in. For those of you who are unable to join with the same input, please try refreshing it once and then join back. Because I can see many people joining in, so the link is working. We have around 26 players in the room now. Wait for a few more of you to join, and then we can begin with the quiz. I think you all can see start game on your screen. Let's begin. We'll have first question required to check the culture and the specimen for sensitivity. Um, Second question. Of you got it right. And early onset of AMR is not associated with heart diseases. This is a trick question. Just letting you know. Two people got it right. The first discovered antibiotic is not penicillin. Penicillin was the first commercially mass-produced antibiotic. A question from the discussion. What would you do as a clinician if blood culture results were negative and an ongoing infection was not suspected? It could be a multiple select question, so you can have you can choose multiple options. Discontinuing antibiotics is the right course of action if you see a negative culture result and there is not an ongoing infection. You are supposed to drag the options and then arrange them in the order that you see fit. You see those two bars can help you to drag this up and down. Correct always HIV, diabetes, AMR, and then heart diseases. None of you got it right. It's okay. A 20-year-old female comes to the ENT OP with an earache and discharge. Choose all the course of action for antibiotics administration. You can choose multiple options. There's no just one correct answer. The absolute indication for using soap and water for hand hygiene is we have DP leading the leaderboard right now, and Sahania just moved up. During doffing, which PPE is considered most contaminated, and during donning, which PPE is considered the most sterile. You were supposed to type something here. And for a hint, the answer is hidden on the slide itself. For those of you who responded gloves and mask or N95 or gloves with anything, your answers were correct. I'm sorry if it's not displaying the leaderboard, but you were right with your answers. Spill management includes the following steps, arrange in order. So you mark the spill area, you confine the spill in bifid and absorbent cloth. Then you're allowed to soak in the disinfectant, and then you clean it with 5% hypochlorite solution. That is the correct measure to manage the spill. Pass, got it right. Oh, these are some fun quirky names you have. We have another question. This is from surveillance. The air surveillance indications of the CDC include the following microbiological parameters except which of the following is a possible side effect of antibiotics? all of these can be side effects of misusing antibiotics. Guanfacine was the first commercially available antibacterial. It's a sulfonamide. As I said earlier, penicillin was the first mass-produced commercially available antibiotic. But before that, there were other antibiotics which were discovered. A 16-year-old comes to your OPD with a fever due to sore throat. When is it correct to prescribe antibiotics? This was the question asked in the comments. Are you not able to join in? Those of you who got kicked out from the quiz, can you please try going back to the link and then enter the refresh your page and enter the code again? I'm so sorry. I'm trying to figure out what the glitch is. Please feel free to enter your answers in the chat box in the meantime. I'm so sorry for the trouble that it has caused you. Okay. I think I'm supposed I am the quiz now since none of you are able to respond over there. Mhm. I'll share the link for the certificate. I'll share a feedback plan right now. I'm so sorry. I think you all were only able to answer the first 10 questions and then some glitch happened and you were not able to join back again. But in the interest of time, I think we can end the quiz here. Thank you so much for participating for the while that you did. And I'll just share the leaderboard for uh, participants for everybody. So we have a winner. We have KJ as the maximum score. Can you please know who this person is so that we can congratulate them? We have Haunted Cactus as runner-up. We have DP. Oh, sorry. So DP is the winner with 41% accuracy and 531 points. Maybe know who DP is? And we have Sahania as runner-up with 28% accuracy and 2053 points. Devam Prati, congratulations, Devam. And thank you so much, everybody, for being such a good support and playing along with me. I'm so sorry for the glitch that happened towards the end. I'll try and post the link in the WhatsApp group for you all to try this quiz later on if you wish to. Okay, sure. I'll just scroll through this and you can see all your results. I hope it's visible to everybody. Bus was a good competitor. They also had 27% accuracy. When we go about now, we have these three as the top three players: DC, Sahanya, and Radhe. And here we have a top 10. Thank you so much, everybody. I'll just share one final link with you all, which is the feedback the link for your certificates. No, there is a third position. I'll just show it to you. I hope you're still able to see it. First one is GT, second one is Sahanya, and third one is Radhe. Thank you so much, everyone, for joining in. If you just give me a minute, I'll share the link for the feedback form. This is the final QR code that I'm asking you to scan. Don't scan no more QR codes from my end for today. But please do scan this QR code, fill your feedback, and please just submit your feedbacks. This we'll be only be sending certificates to those people who submit this feedback form. Please take out 10 minutes and give us your feedback. This is a very simple form. We just want to know how did you like the session? What did you learn from it? Your key takeaway message and all that basic information. Thanks so very much for participating. Also, I would like to share some links with you all. If you'd like to check out what Against Superbugs is doing, you can follow us here. Please to fill up the feedback form. Thank you so much for joining in. If you have filled the feedback form, you can start logging out. Thank you so much for giving us time on a Sunday and joining in a conversation on antimicrobial resistance. Hope you now understand the gravity and the importance of this subject a bit more and would take a step in educating your peers about this issue as well. Thank you once again, and we look forward to see you in more of our events in the near future. Please stay connected. Please, if you do want, please do follow us on our social media channels. We keep organizing these events, some in offline and some in online formats. And we would love